Oh, no, there you go.
Okay, so hi, I'm Hannah, and I work in pharmacy and pharmacology, and what I'm really interested in is the workload pressures that community pharmacists like this man here experience day to day. And the reason I'm interested in this is because about 10 years ago, the contractual frameworks that pharmacists work to with the NHS changed quite significantly. And this led to them taking on new and enhanced clinical roles. And as you can see, everyone was going to benefit. 10 years on, we've implemented these contractual frameworks, but what we actually know is that not everyone has benefited. Community pharmacists feel like their workload is overwhelming. And when I interview them, they say things like, it's just impossible these days, it's like a relentless treadmill. And so what we've been doing is we've been looking at why this might be the case. So if you look at the service level data, what we can see is that their original core functions, like dispensing prescription medicines, has increased since 2005 by 39%. We're all taking more prescription medicines. But what we also see is that these new enhanced services, like what you see on this brain, or the NMS, the new medicine service, and things like smoking cessation, have gone up by 69% in this time. And MURs, which are medicine use reviews, have gone up by 1,789% because they came in with the new frameworks. But we haven't seen this change in community pharmacists. So we've only seen about a 10% increase in the numbers of pharmacists across the decade, but across all sectors. And so we're actually seeing quite a big step change in how much work we're asking pharmacists to do. So what I want to know is, how do we know if we're giving pharmacists too much work to do? They might not have been doing enough before. They might have actually been sitting twiddling their thumbs behind the pharmacy counter. We don't know. But more importantly, what I'm interested in is whether this might actually be affecting patient safety, and that's quite difficult to measure. And part of the answer to this lies in how we conceptualise workload. So typically in pharmacy, what we thought of workload as is in terms of the task demands, so how much work we do in any given moment. But actually, as a psychologist, I'm much more interested in the other factors that are creating workload. So the working environment and employee characteristics, like how fatigued we're feeling today, or how much expertise we have for the task. And I've been interviewing pharmacists, and when we talk to them about their workload, they say things like this. There have been times before when I've had to pull the cord out of the phone just to stop it for a few seconds so that I can think about what I'm doing if I'm checking a controlled drug like methadone. And so pharmacists routinely report that they're continually distracted in their day-to-day practice. So I've been measuring their individual perceptions of workload, and the reason we've been doing that is because we know from other industries, our engineering colleagues will know well, that something called mental workload, which is this perception, is actually quite well related to task performance. So when we report very high mental workload or very low mental workload, we actually see decrements in, or declines in task performance and errors. So we wanted to do this with community pharmacists. So we brought them to our pharmacy practice suite, which looks like this, at the University of Bath. It's down in the basement. This is where we train our student pharmacists. And we asked 104 community pharmacists from around the UK to come and take part, as well as 97 of our final year pharmacy students. And we asked them to carry out a routine pharmacy task in one of our lovely booths so we could control the environment. And we measured their task performance whilst they carried out a routine task. And we also measured their mental workload. And the routine task we asked them to do was what's called a final accuracy check task, where they have to compare the medicine with the prescription and also the pharmacy label to make sure that everything matches up. And they actually do this every time before you get a medicine. You wouldn't know it because quite often the exchange is really quick. What we didn't tell them was that they had to check 50 items and 5 of those had an error on them, so it could be on the label or with the medicine itself. And we were measuring how many of those they detected and also how much workload they reported and their perceptions of their workload. We found that 75% of students missed one or more error, but also that our qualified pharmacists, 65% of them missed one or more error, which is not what we want in day-to-day practice. For the students, what we found was that actually their workload perceptions did predict detection of errors. So those that scored above the median for the group, they detected 12% less errors. Whereas the pharmacists, we actually found that their workload wasn't predicting their performance on this task. But what was predicting the performance on the task was the type of error. And we found that actually they were much worse at detecting labelling errors than they were the medicines errors themselves. So they could spot when the wrong drug had been made, but not when the wrong labelling error had been made. The upshot of this is we made 2 recommendations for pharmacists. 1, look out for the workload of your novice pharmacist, and 2, let's start looking at how we design pharmacy labels in the future to try and stop more errors. Thank you very much.